hematology, oncology, pathology, anemias. So before we delve into the specific types of anemias, I just wanted to kind of start with an overview talking about how we subtype the different types of anemias in order to understand what we're dealing with. So when I'm given a CBC, a complete blood count, I'm usually going to first look at the MCV. Okay, so automatically you're able to tell whether the patient is anemic or not by looking at their hematocrit and hemoglobin levels. If those are decreased, you're looking at a patient that has anemia. And the first value that I look for is our MCV. Now, the reason I do this is because if the MCV is less than 80, it is considered a microcytic anemia, and there's only a couple types that can be that. And if the MCV is greater than 100, then I know it's a macrocytic anemia, meaning that it could only be a couple causes of that as well. However, if the MCV falls within the 80 to 100 region, then I'll have to look at different markers to help me define what type of anemia I'm dealing with. But that is the first thing I look at, the MCV. Second thing I look at is the reticulocyte count. The reticulocyte count is important for me because it tells me whether we have a good bone marrow response or not. And then that will lead me to the conclusion whether the anemia is secondary to a poor bone marrow response or it's causing an increase in bone marrow production of reticulocytes. Now, what do I mean by this? Reticulocytes are just the preformed portion of a red blood cell. Okay, so they're just before red blood cells formed, we have the reticulocyte. Now, if we have a high reticulocyte count, that means that there's peripheral destruction of our red blood cells, but our bone marrow response is good. We're producing red blood cells in response to anemia. That's destruction in the periphery. However, if I have a reticulocyte count less than 3, then that means that I have a poor marrow response, leading to the conclusion that the anemia is most likely secondary to a bone marrow issue. And you'll see that a lot of the times in our CBC for what's important. Lastly, interpretation of iron studies is really, really important for determining what type of anemia we have. Because, mainly for microcytic anemias, we have to look at our iron levels. Now, there's 4 types of levels that I look for when I'm deciding to interpret iron studies. The first level is the serum iron. Okay, so I look whether the serum iron is increased, decreased, or normal. The second thing I look for is transferrin, also known as TIBC, the total iron binding capacity. The third one I look for is ferritin levels. And lastly, which is rarely ever used, I look for saturation. But the main 3 is serum iron, transferrin or TIBC, which is the same thing, and then ferritin. And your TIBC and transferrin compared to your ferritin will always be opposite. So that's kind of one of the rules that I use that I always like to use. It's kind of a cheat sheet to help me figure out what's going on. Your TIBC and transferrin, same thing, will always be opposite to your ferritin. So if you have an increase in TIBC transferrin, you have a decrease in ferritin. And same thing goes vice versa. Now, what do these mean? Serum iron levels just tells you how much iron you have in your serum. Transferrin, or TIBC, is a protein that helps transport iron in the blood. Okay, and what this does is it takes it to the liver, okay, from our GI tract, which is where we absorb it, and we take it to the liver and bone marrow, where macrophages store it. Okay, ferritin is what stores it intracellularly. So transferrin, or TIBC, helps detect how much iron is bound and traveling in blood, whereas ferritin helps detect how much we are storing it outside of the blood and inside macrophages.